thanks to my diplomatic colleague. It's very effective, though.
It is.
Okay, so in the interest of sleep deprivation and low sugar levels, we've convened and decided, and also quite candidly getting feedback from a number of you, sitting through 50 minutes of readouts, at the end of the day may not be as welcome as it was in the middle of the day. So we're going to, since the 3-minute border was hard to retain and it was closer to 5 or 6, what we're going to aim for are 5 presentations, not 10. We're going to capture everything, but we're only going to invite 5 up here. In the interest of fairness, we're going to apply a simple methodology of flipping a coin for each pair, right? Between, say, 1 and 2 and 3 and 4 to see who actually gets to present. So no bias in the selection criteria whatsoever. So are you ready for the first flip?
Yes.
This is between groups 1 and 2.
Heads
is 1. I can't flip the
2.
Group 2, you are the first winner. So if you're in group 2, please come up and make your 3 to 5 minute presentation.
My name is Dan Hirsh. I'm from Atlanta, Georgia. I'm on the clinical side. I'm a pediatric emergency medicine physician at Emory University in Children's Healthcare. We had a vigorous debate, and we came up with 3 topics, but we ended up with one question that I think we all agreed on the most was, how can clinical decision support systems be made to give a more credible and actionable decisions to help physicians, patients, consumers, sort of the gamut of the healthcare stakeholders. The approach was to, can we collect some data, patient-centric data, their preferences, some physiologic data, their past medical history, their genomic data, their behavior. Can we apply this to some knowledge we know about disease process, what the medical outcomes can be? Can you look at, if there's an institutional success rate for different things? And then can we build a model and get some inferences so that when you have a specific scenario, you can provide the clinician and the stakeholders not just an answer, but perhaps an explanation to an answer or a group of answers, and ideally somehow be able to, if the physician or the stakeholders get an answer, can you query and say, I want to do something different here? How does that change the decision making? Clearly there's challenges to this, as we don't always know all the data necessary, whether it's about the patient or the medical knowledge. We don't necessarily know how the models work or what the best models may be. And even if you have the perfect data and you have the perfect models and you're able to make a perfect inference, can you explain, you're going to get an answer, but can you explain it to somebody at the right level, whether it's physician or scientist or a patient? So how do we do that? We thought our test bed could be, or I thought a test bed could be some sort of chronic disease where it's very complicated, like if you're diagnosed with some form of cancer. Clearly you could look at patient preferences in terms of quality of life. You can look at their past medical history, what medicines they're on. You can look at their behavior and their course of genomics. For some cancers, we have a good understanding of what their survival rates may be. Cancer is very dependent on cancer treatment is very dependent on what institution they're at and where they are geographically. So if you take all that data and sort of understanding about that, could you get some information about that? And then hopefully provide the physician maybe a list of choices and explain why these choices are necessary, and be able to present that in an easy way for the physician and the other stakeholders to make an informed decision.
Thank you. Now, between 3 and 4.
3 and 4, and the winner is?
Well, I can't do it. 4 is heads. 4 it is.
Group 4. Feels like Vegas odds.
Yeah,
you know,
I'm expecting someone to give me the binomial distribution on this and let me know.
Yeah.
Hi, I'm Tim Bickmore, Northeastern University Computer Science. So our group discussed a number of concepts, but the one that we decided to go forward with is the research problem is looking at the process, the fundamental process of managing the health of an individual, and sort of exploding that away from the model of having them come in for a clinic visit on some sort of heuristic schedule, and going much more to a process and information flow model in which everything is driven by assumed health condition and trajectory of the patient and knowledge of what information is needed at what time. So a key aspect of the model is the representation and reasoning of time. So models of attention that indicate what information is needed when, models of data fusion and diagnosis that take into account the time-varying nature of data, and intervention planning that takes time into account as well. So the approach is to develop fundamental models of temporal representation and reasoning, develop cognitive models of how clinicians reason about time, and also developing approaches to temporal planning, data fusion, and models of disease. Challenges and risks. So of course, if you don't have good underlying models of physiology or of disease, then it's hard to build these higher level monitoring and planning approaches. So that can be a risk. Those are prerequisites. And for a test bed, you first need to identify domains in which temporal reasoning is known to be important, in which time-varying nature of disease is important. And we think it's amenable to developing common simulations that you could have researchers test against.
Very crisp. I think that actually was below 3 minutes.
5 or 6.
5 or 6? Let's do
Heads,
it.
it would be 6, and it's 6.
Oh, it looks like it's going to be an even run.
Yeah.
It's a two-headed pointy. Who's 6? All in the back? All right. Good. No, we got 3 more. No, we have a couple more.
2 more.
2 more. Yeah. Take your time. We're good. We're on schedule.
Where does it go in? Goes in there?
What's the issue here?
Where does it go?
Oh, do you want to plug in?
Yeah, since I have
Okay, I've got some slides.
not many, but
Yeah, well, what happened to the whatcha-hoogie? It's right here. There you go.
Yeah, you're there.
You're almost on. You're on.
Okay. Anyway, we are group number 6, and the topic of our
Smart grid.
title is Smart Grid for the Healthcare Enterprise. So here are the members of the group, and it so happened that my name is Ram, or Random Access Memory, so they randomly decided that I should talk, and I thought I randomly decided what I should talk, so this may not reflect the group's consensus, but anyway, since it's a group and not supposed to have consensus, but that's so. The problem statement is the following: it's how to instrument, visualize, and assess quality of communication across the healthcare enterprise. So this whole enterprise where you have devices communicating with other devices, devices communicating with human beings communicating with human beings. That true? Maybe. And human beings communicating with the computers, and human beings computing with animals, and human beings computing with all kinds of things in the OR, as Julian Goldman here would say. All the mess in the OR as such. So there's a lot of communication happening. And not only communication happening, communication is also happening at various levels of fidelity. Like you have communication happening at the signal level, and you have communication level happening at, I said this to you, and you did what? You know what happens in the OR, actually, okay? People are turning the wrong instruments and things like that. Happens all the time. So that's a problem. How do you deal with this, and how do you develop a computational framework, since you're talking about IT here,
for addressing this. Yeah. So in terms of the approaches, we have about 5 of them here. I kind of mined this from the sheets that I got. One is discovering the web of communication, which involves a lot of research areas, like using machine learning and data mining techniques to mine all that information and data which is out there and put it in a particular form that can be communicated, and representing the fidelity of information at the right levels of abstraction, instrumenting this entire healthcare enterprise, the web, and how do you monitor this thing. And then we have a formal representation of communication. How do you represent this whole data at different levels of abstraction, like using techniques like UML, ontologies, probability networks. Then we need to develop techniques for validating this communication infrastructure, techniques for sensing changes. A lot of times changes happen in this healthcare enterprise which no one knows what's happening, and only when you get your bills from your doctors you know that. And finally, understanding the role of epigenetics. We have 2 talks about systems medicine and systems biology. The idea is that one of the major problems could be to deal with the notion of epigenetics, and computationally, how does it fit into the whole thing is something which is important to address in this web of communication. And in terms of the test beds, 2 test beds we decided to look at. One is the primary care, and another is the trauma care. And apart from that, I don't have anything to say. Thank you.
There was nothing random about that.
Yeah, that was not random. That was sequential memory.
That was excellent.
Okay,
Okay.
and now
Teams 7 and 8.
7 and 8, heads would be 8. 8 it is.
And you call that random?
I'm going to play the lottery next. Yeah. Perfect record.
Is 8 coming up?
8?
8?
Wait, okay. So now I'm going to do, we'll think about that for a moment. 9 and 10.
It's a head.
Heads, 10.
10. Very nice. Very elegant.
Yeah. Can someone work out the 1 and 2 thing? I'm a little worried
The
about
odds of,
Well, called 2, but 8. Eight.
but 2 didn't actually present, 8
Yeah,
presented.
Was there,
So
was
who
there
did we
a
miss?
conspiracy to?
Yes, it was a conspiracy. Okay, but
Okay,
I'm
keep
going
on
to
going.
present.
All right.
Because this is taking out of my time. All right, so this is actually group 10, and we're going to propose personalized healthcare technologies, except personalized for the physician. And so what we spent our time working on was the question of how do we take these massive data sets that we're all going to be run over after all the work that we're doing in this space, and create effective feedback loops of that information to inform clinical care. So the question is then, as we look into our approach to this, one of the major challenges within this space is how to make process data of what a particular physician is doing reproducible. So what are the right ways to capture, what are the right ways to represent what's happening in the process, and this is a very different set of information than what is captured by the transactional data of the healthcare systems today. And then how do we connect that process information to outcome measurement? Okay, so let's assume for a second that we could do this. Then there's a question of, okay, what are the other challenges in the system? Because we're now doing a different type of quality assessment of physician outcomes. So there's challenges in terms of making sure that it is not top-down or hierarchical in terms of what processes or what decisions can be made by physicians within the system. So you need to retain the control of the individual physician. You want to make sure that the data is not used in punitive measures. Otherwise, people will find ways of opting out or not participating within the system. And of course, there's real challenges in terms of physicians being willing to engage or accept or work with that feedback within that. All right, but in terms of something that's probably more of a technical or data-driven challenge within the space is how do you create the right cohort data to help inform your assessment of outcomes? So I'm a computer scientist. I'm playing a physician on TV. How do, and I have the worst outcome data. Well, it turns out that I'm willing to accept the sickest patients, or for some reason, whatever, in the practice, that the people who are probably going to have the worst outcomes tend to come to my clinic. So how do you work the data so that it doesn't actually penalize people who are actually perhaps performing the riskiest or the most difficult medical procedures? All right. So on our last point, we had a great discussion on what kind of test beds would be useful in terms of pushing this particular research agenda. There is a certain cleanliness to doing something that's just within the acute care setting, because then you would have more data available to you to inform this particular feedback loop. But we were particularly interested in what we could do in the outpatient setting, because that would actually provide a wealth of information in this feedback loop to physicians that they might not have access to regularly. And we actually debated a number of different disease conditions, and having computer scientists do that is kind of terrifying. But one of the things that we came to was, for example, asthma. Diagnosis and treatment of asthma, because you have return ER visits that are very expensive and traumatic and sometimes life-threatening. But you have a tremendous amount of data that is in the environment, home air quality data, environment air quality data, as well as the breath stress test, and in terms of use of medication. And all of that data should be informing what clinicians are doing, and so it's appropriate that that would be very effective in terms of that feedback loop in terms of clinical support. So personalized healthcare for physicians. Thank you.
So let me be clear, there's no group 2, is that correct? All right, so then
Do
we'll
they
do...
not want to present? Okay, all right, so 2, you're up.
Okay, so we'll do 1 and 2, no,
Oh, we're going to flip it again?
oh, no, you're right.
We picked them.
2, yeah,
2, you're
2.
up. Let's go.
2, you're up.
We were just having this exact debate.
That's exactly,
We're just going to flip a coin. Well, it's better than death panels.
I'm putting this on auction.
Hi, my name is Lena Mamykina. I recently graduated from Georgia Tech, and now I'm a research fellow at Columbia at DBMI. We actually, it's interesting that in the second part of our discussions, I think there are certain themes that are emerging that people talk about. So what I'm going to talk about is going to sound very familiar. The problem that we kind of took, we discussed several different directions, but the problem that we identified was a current lack of understanding of trajectories of health and disease in social, cultural, and economical context, and determinants of health and disease on individual and population level. And this is very similar to what some of the other presenters were talking about. Inspired by the afternoon presentations, we decided that our approach is going to be taking a systems view on health and disease development. And the way we thought about doing that is integrating multiple existing data streams, especially the ones that are going to be coming out of the new electronic health record, a new generation of electronic health record systems, and also the emerging electronic patient record systems such as Google Health or Microsoft Vault, among others. So we were thinking of integrating medical data with lifestyle and psychosocial data, integrating genetic and environmental data, and using all this to model the progress of diseases using patient data across populations. We see some of the challenges and risks in this is that, first of all, there probably is going to be a significant investment at the beginning, and the outcome of this work is not clear yet. All these diverse data streams may or may not end up being predictive of anything. And that especially at the granularity of data that we capture with current technologies, again, coming from different sources, it's not clear what the outcome is going to be. However, the promise is great, so it might still be worth the exploration. And that there were some comments regarding financial systems and the current reimbursement models that reinforce status quo and are not very well adapted to this type of longitudinal care that takes into account all these diverse sources of information. The test bed. Again, similarly to what you've heard before, we decided to focus on a few conditions, complex conditions where environmental factors are very important, such as diabetes or obesity. And we felt that for those conditions, there already exist very diverse sources of information. For example, social computing applications, where people with these diseases come together to discuss some of the social aspects of the disease and some of the environmental factors that impact them. But then there are also clinical records for those individuals that could be combined together. And that we would potentially need to incorporate other data sources, so looking at the home, looking at the employment, the social networks, the medical records, the community, and that concludes the presentation. So, thank you.
Yeah, just wrap it up.
All right. So, one more? We're doing one more?
Well, I
Is
thought we
anyone
just-
really dying to present? Seriously, does anyone? We'll capture everything. Yeah, I mean, if we want to put everything on the wall, so if you didn't present, that's okay. We'll still get it.
We just hypothesized presentation listening fatigue,
Yeah,
and so
yeah, because we're at the end of the day here. So it's 5 o'clock. Do you want to go? What? Okay, so let's do some more. So, team 1, come on up.
that's
Team 1. Democracy wins. So much for the coin flipping.
Okay, so we were looking at process aspects. The very first statement was that we should completely throw out the existing set of processes, move from episodic end-of-life event-triggered care to continuous, lifelong, proactive, predictive, outside of clinical settings care. And one interesting observation was that the locus, as well as moving from the hospital perhaps into the house, is moving into other social institutions, especially schools where kids have their first sort of health education. A lot of their diet and exercise habits are set there. Some of their peer networks are set there. Also churches. And so new social institutions. In terms of the sort of a focus of research, we then moved to behavior change, which is the mechanism by which we can, is necessary if patients are really going to take agency in managing their own health. They have to be convinced to a much greater extent than they are now to take better care of themselves and listen to advice from a variety of actors. Those actors would extend beyond the physician, and assuming, right now physicians have automatic high levels of trust and influence over patients. As we move to a more distributed system with different actors, and especially to patients retrieving their own health advice, we need better support for them to vet the advice, to do automatic provenance and help them make better decisions, about lifestyle and certainly also about health. I think it's good to remember that also some of these social network sites, patients like me, etc., it's not just an informational function. There's a peer support function. There's also a sense of agency that they give patients and caregivers that is in itself very important as part of healthcare. Personalized messaging, mass customization are a suite of techniques that are really only possible in an information-rich environment, so they enable new kinds of persuasive effects on patients. Let's see, test beds. All right, so we were thinking about test beds in terms of persuasion, influence. Attitude change is relatively easy to study, even at mass scale. You can take surveys, you can see how people's opinions are changing. You can even look at blogs and Twittering. In terms of large-scale studies, though, we really want to get to behavior change. So that includes epidemiological and psychosocial studies. I hope my tongue is still attached. But these large-scale interventions will be needed at some point for ground truth. But there are also some very interesting portals like Microsoft Health, Google Health, which provide linkage between sort of social networking and conventional health records, and provide a very interesting context for exploring some of these effects. And finally, I want to make a push for research in developing regions, which is a different context where a lot of the barriers to doing clinical trials here are not evident there, and you can do a lot more with a lot less money. And similarly, and the effects are also often much larger. So I think that's worth keeping in mind. And that's all I had to say.
All right, I'm Steve Downs. We were group 3. We talked about a number of different possible things and struggled with this, and in the end chose the one with the best name, which was digital epidemiology. The research problem we came up with was how to capture learning from the data of health and healthcare to improve outcomes and reduce costs. And there are a lot of sort of research problems, research challenges under that we thought were interesting, including making sure you deal with messy, incomplete data in multiple formats, the issue of how do you maximize public utility from personal data while somehow also managing to safeguard privacy, looking at technical solutions for that. Scalability is an issue. We talked also about the issue of hypothesis generation, whether it be data mining for hypothesis in order to generate hypotheses or techniques for automated hypothesis generation. Obviously, there's a lot of data mining techniques that need to be done. And we talked a lot about imaging and sort of the challenge and value of trying to figure out how better to be able to data mine images in the context of wider data sets. The challenge of how to make data available for this purpose. And also the importance of enabling mashups. So it's not just health data, but also other data that can be added. For the testbed demonstration idea was, first of all, we posited that you need a very open, flexible architecture for all of this to work. So the idea was to create that kind of architecture. And then in terms of the population, we had a lot of back and forth and debate about, do we select for certain diseases or certain conditions and target this fairly narrowly? But instead came down on sort of the idea of a general population that's not limited by particular diseases. More of a Framingham type study, but not limited by geography either. And then the idea that this would be augmented by environmental data. And that's it.
That's great. Come on up. Group 9 or group 5? 5, 7, 9? 5. Here we go.
I think it's called the revenge of the odd numbers.
So group 5, we decided to focus on communication. We made the assumption that the content is all there, then we're really talking about how the appropriate communication is done at the appropriate time to the right person. At each phase of the process. By the way, we felt the processes didn't go far enough and should include things like stages like end of life, which are really difficult ones to go through. So the problem would be, how do you communicate through some kind of efficient, knowledgeable extraction, reduction of complexity? Is it a narrative? Is it visual? How do you bring these together? And we called it medical records that explain themselves. We're not quite sure what that means, but approaches, there would be many different approaches. For a more prevention stage, maybe sound bites, suggestions, reminders. You don't want to be told a lot. When you're in the diagnosis stage and you're really working closely with the patient, you want much more information. Again, different levels for different people. We said we might want data, we might want narratives, we might want visuals, we might want to know the quality of the data. I'm sorry I left the details back there. Somebody had said to me, please say the details, but I've left it there. We also wanted a supportive knowledge base. Basically, explain itself partly includes knowing when to drill deeper and ask, I'd say, I don't understand, tell me more. And then we also said follow-up. Follow-up might be supportive for the patient. It might be more like sliders in the sense of for the provider, where the provider wants to know where the problems are, so they sort of dial down and say, tell me the worst things, okay, tell me a little bit more. Challenges and risks, many. We had a long list. First of all, any summarization assumes a large background database of knowledge, different for everybody. So different for the stakeholders, even different for different providers in the same area. Secondly, it varies by the context, so chronic or acute. And then the language of that communication has to be appropriate. We said that it would be appropriate to do at least 2 test beds, an acute, and having a cardiac physician in the group, we chose that. So we said cardiac bypass, and the issue would be, how do you communicate before, during, and after, and what are the methods you would use? An example we used was, let me come back to that. And the second is chronic. And in the chronic area, again, we stayed with the heart, and we said, suppose we chose an existing large database of heart problems. We thought about the Framingham database, and that might be too old. But we said, suppose you try to take what exists, digest each case, make a narrative or some kind of a communication, show it to somebody, a physician, and then ask them to predict what the case would do going forward. So some kind of a iterative process to try to see whether the communication is working. And again, to do that for patients, providers, family, and so on. Thank you.
Great. Thank you. Thank you. Do I hear a 9 or 11 or 7? No. Okay. Good.
Hello, I'm Tiffany Veinot. I'm from the University of Michigan School of Information and School of Public Health. I'm reporting for Group 9. Our problem area is that there does not exist a means to deeply understand stakeholders' experiences throughout the healthcare system. And we believe that these experiences are extremely important to better understand because they directly impact the delivery and quality of care. And by stakeholders, we mean patients, we mean providers, we mean family. It's the whole range of players in the healthcare system. The approaches that we developed were to develop a system infrastructure to collect, integrate, and process health-relevant information in a timely fashion that works across disparate physical settings, stakeholders, processes of care, sources of information, and devices. And to study the experiences of patients and caregivers to understand the current processes and the many barriers that people encounter when navigating the healthcare system or trying to work within it. And the challenges and risks that we saw in this process would be the fact that we want to engage multiple stakeholders, which requires us to have buy-in across multiple groups. There are also legal, regulatory, ethical, intellectual property, and liability issues which may be relevant. And by intellectual property, one of the biggest issues that some of our members have encountered relate to the proprietary nature of much health IT information, which makes it extremely difficult to conduct research about systems. We also felt that rapid prototyping would be a potential challenge, but might provide an opportunity to collect data in new ways. We also felt that metrics were a particular challenge. It was very difficult to determine what success is. In terms of test beds and demonstration, we felt that a theoretical sampling approach, like in qualitative research, would be best for this type of thing, to look for variation across different kinds of diseases and settings in order to try to find generalizable principles. Like the previous group, we were looking at acute and chronic cases. The acute case that we came up with was H1N1. And in terms of a chronic case, we were looking at diabetes that might be managed with insulin pumps because of the nature of data that would be involved. And we were looking at it across multiple settings. So in terms of this, we would look at trying to create those particular approaches in those environments for generalizability. Thank you very much.
That's great. Anyone left? Yeah, come on up.
Hi, I'm Zeeshan Syed from the University of Michigan. I'm representing Group 7, and basically what we talked about was the idea of personalized, lifelong health management. And this was motivated by the observation that we presently lose a lot of opportunities by segmenting a patient's profile and restricting our analysis to were essentially very limited slices of a person's life. We either study patients before they come to the hospital, in hospital, post-hospital, or when they're healthy in a disease state, post-disease state, or in a chronic disease state. And this lack of complete, accurate data analysis is associated with considerable inefficiency. So what we talked about was basically gaining by adopting a more continuous view of healthcare in terms of approaches by collecting data from multimodal sensors, factoring in genomic information, factoring in lifestyle information where possible, and then bringing together AI methods for lifelong monitoring of a person's information, not just to do standard things like alerting and detecting things, but also for motivation, guidance, caring, compliance, a whole lifelong suite of things. And then we talked about the need to present data to clinicians and also caregivers in a compact manner. In terms of challenges, anytime we talk about collecting data over a person's lifespan, storage is a key issue. There are also issues associated with basically collecting quality and reliable data. There's a challenge of confidentiality. Liability ends up being a concern anytime we're talking about having enormous amounts of data being collected for a patient. And this ties into essentially a key problem of needing to realize a sweet spot where we're neither over-reporting things nor under-reporting them. Some of the other things that we talked about was the need for HCI and interfaces to communicate findings to both the patients and caregivers. Also the question of what the path or trajectory would be to building the system. In the sense, does it incrementally get built up, or does it just come about together? In terms of test beds, having this data allows for much richer longitudinal clinical trials of a new kind, but we tried to focus it a little bit and talked about a hypothetical situation where, for example, we might take patients who've suffered heart attacks and have half of them be treated using standard clinical practice, and for the other half, capture ECG data using things like iPhones and also weight measurements and other such thing, and use automated algorithms to distill this data, find risk markers, communicate these findings to caregivers, and see if there was a difference in terms of long-term outputs for outcomes for these patients versus the other population. Thank you.
Okay. So, do you want to make up some wrapping comments? Okay.
So we've come to the end of our work for today. I'd like to remind you that at 6 o'clock we have a reception. We'll have some wine and beer. We'll have some goodies. We'll have a chance to hang out and talk for a little bit. I want to thank the 10, 20 presenters who summarized the breakout groups, and I have a request for you. Many of you either had slides or spoke from notes. If you could make a pass over them, and I can't tell you right now, I'll tell you tomorrow morning where to mail them, but prepare to mail all those. Well, you can mail them to me, it's all right. But we want to capture all of those documents. For those of you that simply read from pages of the flip charts, could you make sure that the page is labeled, this was the report of group 1 through 10 from Thursday morning or Thursday afternoon, so that one way or another we have a summary of each of the breakouts that we can reuse. Tomorrow morning, the original vision was that for the breakouts, we were going to take a whole bunch of Post-it notes and they would have self-organized into topics. Now, as you can see, that didn't happen. We ended up using these flip charts instead of the Post-its. So I'm going to invite you to think about what's a topic you would like to talk about with a group of people tomorrow morning. And I'll ask that people we'll have a clean page, put up suggested topics, which we'll shuffle, and then we have a slightly longer break tomorrow morning, and there'll be sign-up sheets for people to sign up for groups for the topics that they're burning to discuss. One of the things that I can point out to you is that today, everything we did was application pull. We talked about everything from the application point of view. It's wide open tomorrow. If you want to have a discussion about technology push, and here's some amazing technology that you might think about developing that had lots of applications in the areas we've talked about today, that's okay too. We didn't want the meeting to be consumed by that, but we want to have an opportunity to do that. In addition, we're going to have 2 speakers tomorrow morning. We're going to have a plenary discussion about, suppose we really thought about far out ideas, out of the box ideas, way in the future maybe, throwing away the systems we have now, what might we do? And that may well lead to other topics that we'll discuss in breakout. So it's fluid for the moment, but if you think about things you'd like to talk about with people in this room who have an enormous diversity of skills to offer.
That's great.
Okay.
Oh, that's perfect. So I think we're done, right? Zach, do you want to any comments before, because you're heading out, you won't be here tomorrow. And I just want to congratulate you all. Really great energy, consistent energy levels straight through. Good I mean, it was really impressive. I was suspect of whether or not we pulled that off. So I'm really testimony to you. Why don't you?
So I just want to know that obviously this area is one that is of national interest. The reason I'm leaving tomorrow is because I have to, leaving tonight is because I have to chair another meeting at Washington about the widening use of electronic medical records. And for that reason, I was very heartened to hear about non-medical record applications in this meeting. And the aspects, for instance, of communication and presentation at a system level that go beyond medical records I think are important and are crucially not addressed by some of the national plans. And so with that, I wish you well, and I look forward to working with Susan after the fact to synthesize the results of your work. And so thank you very much.